A very warm welcome to all of you joining us today on yet another edition of The Spotlight. As we all know, since inception of the independent television network, we have always strived to be a socially responsible media organization, in addition to providing news which is relevant to the times and quality entertainment to our viewers. It is our duty and responsibility to create awareness on crucial topics in different dimensions in what we call life. We go above and beyond to provide our viewers critical information to foster an understanding in important issues in society. So today we have with us a senior lecturer and medical geneticist, Dr. Padmapani Padeniya from the Department of Anatomy, Faculty of Medicine from the University of Kelaniya. Every year on the 8th of May, many people from around the world unite together as one to observe what we called International Thalassemia Day. Doctor, thank you for joining us today. And this week, the past week, we have been talking a lot about this disorder, this genetic disorder that we all know as thalassemia. My first question to you, Doctor, is what is this all about?
Marilla, thank you so much for your kind introduction. And let me begin this discussion as like this. So, in medicine, there are different categories of diseases. You call it infections, you call it cancers, and then there are autoimmune disorders, and then inflammatory disorders. And there's one such group, you call it genetic disorders.
Yes.
So, if you take thalassemia is the commonest single gene disorder in the world. And also the thalassemia, it is the commonest genetic disorder causing hereditary anemia. Anemia, you may have heard, in Sinhala we call it Niraktiya, and it's the commonest genetic disorder causing hereditary anemia.
Doctor, are there different types of thalassemia, or is it just one overall term that we hear?
Good question, Mariela. There are two types actually when you take thalassemia, alpha thalassemia and beta thalassemia. Though beta thalassemia is common in Sri Lanka, it is not a clinical problem for us. We don't see patients in hospitals. They are like silently, they are there in the population. But if you take the beta thalassemia, that is the severe form of the disease. But because of this, so from here onwards, my discussion is mainly based on beta thalassemia. And if you take beta thalassemia, there are two different types.
Under that also?
Under that, you can categorize the patients into two groups.
Okay.
You call it beta thalassemia trait, and you call it the other group beta thalassemia major. If you take beta thalassemia trait, they are normal people. They are not, actually we don't consider them as patients because they are completely asymptomatic and they act as carriers. The issue is they are the people who transmit this genetic disorder to their next generation. But if you take the thalassemia major, that is the severe form of the disease. So they are the people who need blood transfusions and they need to be admitted and we have to give blood transfusion, and when we give blood transfusion they develop iron overload. So in order to remove iron we have to give iron chelation, and like that, that is the severe form of the disease.
That is called a major thalassemia.
Beta thalassemia major.
The other group, Doctor, you said
beta thalassemia carrier, or maybe we call it beta thalassemia trait. The
so
same
they
thing.
don't show symptoms, they are
They
asymptomatic.
don't show symptoms.
Now, in terms of the patients who have major issues, they need blood transfusion and all of that, Doctor, what are the symptoms that they see, or what are the symptoms that you all see in general?
As I told you, Mariela, thalassemia trait, no symptoms. Okay, they are completely normal. So, but if you take thalassemia major patients, so generally they are born normally. Okay, they don't have symptoms at birth, but after about like 6 months to 24 weeks, these patients, they develop, they present with this different sort of symptoms like failure to weight gain, recurrent infections, poor feeding, and also fever, and like that, they present with these kind of non-specific symptoms to doctors.
The thing is, doctor, just from a lay perspective, these symptoms are common in another disease as well. So it can be quite tricky for a normal person. I mean, for y'all, it might be very easy when y'all understand. But for us, if we have fever or if we have loss of appetite, the first thing won't be thalassemia in our head. So how do we...
Exactly, Mariela. But then again, when we see these patients, of course, they are anemic. And on examination, we can see that kind of like very significant pallor will be there. And also their liver could be enlarged, their spleen could be enlarged. And so then we suspect there should be a hemoglobin disorder. We suspect thalassemia. So then we have to move on to specific diagnostic testing.
So when a person has some of these symptoms, you all recommend that they come in immediately?
Of course,
Or
they have to.
do you all have a timeline? Do you all recommend that they come in as soon as the symptoms start, or do you all say, do doctors say observe for a few more days, for a few more weeks?
So generally, these patients, as I told you, they develop these symptoms within 6 months to 1.5 years time. So most of the time the parents are more vigilant during that period. So we ask them to come as soon as possible if they see those kind of symptoms in their children. So then we can direct them to relevant blood testing.
Doctor, now global figures show that there were around 100 million thalassemia carriers living with the gene, while around 300,000 children were born with it. Global figures.
Yes.
The figures might vary here and there, but in putting it into our Sri Lankan context, how common is it in our country?
Yeah, Mariela. Now, just to correct a small point, globally what they say is about like 250 million.
No, it has doubled.
Yes. But when it comes to Sri Lankan context, you know, like there are traits and thal major. If you take this thalassemia traits, the asymptomatic carriers, about like 3% of our population, they are thalassemia carriers. Roughly about like out of 22 million people, you can imagine about more than 800,000 people are thalassemia carriers. Now, if you see this Sri Lankan map, you can see that it indicates the carrier density in each and every district. So you can see that 3% of this carrier density, it depends on the district. The density, the prevalence is different. So now you can see that some district like Anuradhapura, Polonnaruwa, Ampara, Monaragala, they are very dark. So that the thing is the carrier frequency is very high, maybe around like 10% of that population, they harbors the carrier statuses.
Do geographical, does that aspect play a part in this, doctor?
Of course. Earlier, they had a kind of like, we had a pre-eradicated malarial area. So during that period, so the interesting point is these thalassemia carriers, they are resistant to falciparum malaria. So you know these districts, they are like very a lot of farming activities are happening, and malaria, the mosquitoes breeding sites were very common in these areas. So the malaria, the people who were in these districts, they were more prone to malaria. But however, because of that inherent protection against this falciparum malaria, so the carriers, they continue to survive.
Right.
Okay, so that's why the density is more in those districts. But however, with population migration, now the whole 25 districts have been populated with thalassemia carriers.
So we see a surge in throughout the country.
Throughout the country, they have been populated because of this migration.
Right.
And if you take the thalassemia major, there are about like 2,600 patients for the whole country. But the most disheartening point, Mariela, is in each year, about like 45 to 55 thalassemia major patients are added to the list.
So that is there is work that has to be done, isn't it, doctor, in
Exactly.
that area? Let's talk about transmission, doctor, this disease. How does it go from one person to another?
Well, you know, I told you, thalassemia is a genetic disease. Okay, so genetic disease transmit through genes. Okay, so now again I'm going to show you this transmission figure. You can see this one. So this disease, it is transmitting to the children through their parents.
Right.
And if you see this figure, the top two figures, they are the parents. Okay, and if you take the thalassemia gene, there are 2 copies. In each and everybody, we have 2 copies. Okay, so what happens in thalassemia transmission is both parents, I told you, they are carriers. You call them traits. Okay, and their one copy is mutated. The other copy is good, so that's why they don't show symptoms. They are completely normal. Okay, but supposing now when both of the parents are carriers and when they are going to when they're going to have meeting and when they're going to have children, the chances of having a thalassemia major child is 25%, and another 25% children of their will be normal children, and the 50% of their children will be thalassemia carriers like their parents.
So the probability is also quite high, doctor.
Quite high, 1 in 4. Yes.
1 in 4. So this might correct me if I'm wrong, doctor, but is thalassemia curable?
Thalassemia, you know, thalassemia, genetic disorders, if you take in general, they are not curable. But then again, with the advancement of genetic platforms and the technology, people are like that, because that in genetic disorders, the genetic defect is a permanent defect in your genome, in your blood. So there are like few ways to rectify that defect. Okay, but when it comes to thalassemia, of course, lot of therapy level, kind of like advanced therapy level research are been happening. And one such therapies we call gene therapy, that is where they try to rectify that defective gene. Okay, so gene therapy level, of course, the people that it's not available in Sri Lanka, but however in other parts of the world, about like more than 100 of patients have been received gene therapy level treatment. But however, it is prohibitively expensive, Mariela. It's about like $1 million per patient. And also now when we manage these patients, the biggest part of the management is blood transfusion. So but there are some in advanced therapy, there are some blood alternatives. Without giving blood, you can give a drug and try to cure the disease. So there are again a drug called luspatercept, that drug, and it is available in other parts of the world and not in Sri Lanka. And you have to give as an injection to these thalassemia major patients, and it's kind of like once in 3 weeks you have to give. Again, it is very, very expensive. For an injection, you have to spend more than $2,000. So you know, once in 3 weeks lifetime, which is not practically possible to a country like Sri Lanka.
What does the Sri Lankan health sector offer to thalassemian patients, doctor?
Of course, Sri Lankan health sector does lot of things. Now, most of these patients, almost all of these patients, 99.9% of these patients are taking treatment through the government sector hospitals. So we have kind of like very good blood donation system, and we have tightly controlled transfusion system in Sri Lanka. So these patients receive blood, and at the same time, as I told you, when they receive blood, they get iron overload. So we have to remove that iron from the body, excess iron, and we have to then give them the chelation. All these things have been provided free of charge.
What about, does the private sector also have such benefits? So mostly we
Private
run
sector,
through the
of course, everything is
available.
available, but then again, it's not free of charge on these
Definitely.
drugs. So that's why I told you almost all of these patients, they are taking treatment from the government sector. But I want to mention here one important aspect, Mariela. Now, If you take the Sri Lankan government, it has to bear the costs of this treatment. They say roughly they have calculated the annual cost for this expenditure for this one patient. They say about like 2,600 USD per patient annually the government has to spend.
Sri Lankan government.
Sri Lankan government. So we have about 2,600 thalassemia major patients, and 2,600 into 2,600. It's a quite big amount. And what they say is about like roughly 5% of our health budget has to be allocated to treat these patients.
So our government is doing its best.
Government is doing its best, and the benefit, of course, goes to the patient. And patients, of course, most of the patients, they have the will to come and take their treatments. But it depends. Some patients, of course, they don't come in time. There are difficulties. There are some from far away. Access is difficult for some people. But then again, most of the patients are taking treatment at the moment through government hospitals.
Doctor, since you brought out access, do we have available spots or clinics throughout the country, or is
yes,
it limited?
We do have available clinics throughout the country. We have the thalassemia now. We have the Kurunegala is a major thalassemia center, Kurunegala, Anuradhapuram, Paramunaragala, and we have one adult thalassemia center in Kiribatgoda, that is the part of North Colombo Teaching Hospital. And it is being looked after by Professor Anuja Premawardhana, and that is the only adult and adolescent care unit in Sri Lanka. So a lot of patients are there. More than 400 patients have been registered there, and daily we are giving blood transfusions and chelation treatment.
Doctor, now when a patient comes in for treatment, or let's say before the treatment there is a diagnosis, what is the process like for diagnosis? Is there a test? How does it work?
Yeah,
what sort of test is
Manila,
done?
now I told you the thalassemia carriers, of course, most of the time we don't see them. They're like incidentally we diagnose them. But if you take the thalassemia major, I told you they will present between
Symptoms.
6 months to 1.5 years, 2 years maximum. And when they come with those clinical symptoms, we direct them to do specific and non-specific and specific blood tests. We do full blood count, blood picture, and hemoglobin electrophoresis. So then we can confirm the diagnosis. So all these major hospitals, this full blood count, blood picture, hemoglobin electrophoresis, those are available free of charge.
Right. Doctor, what happens after? How is the patient looked after? What is the treatment process like after care? And what is the treatment that the hospital offers to a patient suffering from thalassemia?
Yes, Mariela. Now, treatment, of course, two aspects. I told you. Now, the problem is these thalassemia major patients, they are red cells. They get distracted very early life. Like within 1 month, we have to transfuse these patients. So, blood transfusions, of course, is the mainstay of treatment for the time being. So each month they have to come, and we have to check their hemoglobin level, and according to their body weight, we have to transfuse blood. So I told you, we have a very strictly, tightly controlled transfusion program in Sri Lanka, and it is strictly controlled in the sense like, because we have to have a tight control in order to prevent transfusion transmitted infections. That is, you may have heard about HIV through blood transfusion. A patient can get hepatitis, you can get malaria, you can get. So it has to be tightly controlled. It is happening. And the other thing is, like we have a lot of very good-hearted people, and we have a lot of donors in Sri Lanka, and we arrange donor campaigns, and we can collect blood samples. And the important thing is these donors are non-remunerated donors. We don't pay them.
Right, so they come willingly.
voluntarily. Yes.
Doctor, how is the progress like in terms of advancement in treatment? Are we doing good? Is there any current research which is underway for thalassemia?
Yes, Mariel, I told you now the advanced treatment wise, the main treatment is the gene therapy. It is happening other parts of the world, but not in Sri Lanka. And it is prohibitively expensive. Like again, the blood alternatives is another advanced treatment. Again, it is not available in Sri Lanka and it is pretty expensive. This drug called luspatercept.
Any plans on getting it down, doctor, in the near future?
Hopefully. But we have to find a grant. Otherwise, I don't think the government would be able to bear the cost considering the these expenses.
Welcome back to the show, and today we are talking about everything related to thalassemia, and today we have doctor to enlighten us more from the medical perspective, enlightening us further. Doctor, we were talking about progress in technology and medication. We're coming into another more spoken about topic, and also a frequently asked question from doctors. We were speaking about it also off air. Pregnancy. A common question that people ask is, if you are a thalassemia patient, can you have children?
Yeah. So let me discuss this fact in both
Step by
categories.
step, right.
Yes. If you take thalassemia trait, of course, the issue is they don't have symptoms during pregnancy. They occasionally need blood transfusion. For general management purpose, we consider the trait is not a disease condition. It's kind of like we manage as a normal pregnancy. Okay. And they get pregnant without any issue. They don't have subfertility issues due to this defect. I'm asking, due to this thalassemia disease, they don't get fertility issues. But if you take thalassemia major, the interesting point is now these patients, they marry and they have normal, they get pregnant and they have given birth to, with uncomplicated pregnancies, they have given birth to normal babies. So that is a major achievement in our health sector. That is, it shows that we are looking after these patients very well, because they can go to that level that they can marry, they can have children without any complications, they can give birth to normal children. But however, these patients, they have to be looked after at a tertiary care level with very kind of like places where there are a lot of resources, and then where there are blood transfusions are available, these patients can go for deliveries.
Doctor, now this is applicable to patients who are aware that they have thalassemia. But what about patients who, are unaware of their situation, and then they have children, and then later what happens after that, doctor?
That is a very important question, Mariela. Now, the screening part is very important. So now, I told you now this is a genetic disorder, and the genetic defect, of course, rectifying the genetic defect is difficult, and we don't have whatever the advanced treatment, we don't have the access to these advanced treatments. So therefore, the prevention is very important when it comes to thalassemia management. So the prevention, one part is you have to identify the carriers through screening programs. So if you know the carrier statuses, so you can, of course, prevent, you can discourage both two carriers, marriages between two carriers. We can discourage it.
There might little complications there.
Of
isn't it,
course,
doctor?
ethically there might be complications. Ethically is not completely, you can't, it is not acceptable. But then again, in order to prevent transmission, and in order to, I told you, still about like 45 to 55 thalassemia major patients are born annually. So in order to suppress this, we have to at least identify the carriers and discourage the marriages between those carriers, because there is a 25% chance, if both partners are carrier, to get a thalassemia major baby.
Doctor, just to dig in a little further, it's sometimes you do the screening test after getting married. Isn't there an alternative for parents who are in a situation where they're both thalassemia patients, but they've already gotten married?
Yes.
What sort of advice
Yeah, Mariela.
is available for them?
I receive a lot of couples, maybe knowingly or unknowingly, they get married, and when they're going to have children, of course, they face a lot of difficulties. So, of course, you can check, you can ask where they can get pregnant, the carriers, because they don't have any issue for getting pregnant. And when they are pregnant, we can check the baby prenatally. We call it we can check whether the baby is thalassemia major or a carrier or a normal baby. The status of the thalassemia we can check when the baby is inside the uterus.
So, doctor, what about if a patient now is thalassemia major? Another question that we get quite often is, does it cause infertility?
No, thalassemia major, yes, I had to explain it like this, Mariela. Now, the thalassemia major patients, if they manage well, if they receive timed blood transfusion, and if they manage very well their iron levels, the chelation, through chelation, they are not subfertile. They can have normal children. Otherwise, if they don't manage very well, especially with the chelation, if the iron overload, if they develop iron overload, so this excess iron can go and deposit in various endocrine organs in our body, including the pituitary, the thyroid, that your ovaries, that those organs are very important for the hormonal function of the body. So then, if those patients, if you don't manage them well, if they are not keen to chelate their excess iron, they of course find it difficult to get pregnant, and they develop subfertility.
This is why we often, doctor, we hear people say, before you get married, do a thalassemia test. Now it makes sense.
It makes sense. That actually we call it thalassemia horoscope.
Right.
Yes. So, horoscope. You know, like our practice, Sri Lankan practice, we do match horoscopes before marriages. But those things, of course, it's up to the couple. But then again, we urge the couple, if they can at least check the thalassemia status before their marriage. Then,
doctor, why do we give this a lot of importance? Because there are other blood disorders as well, like cancers. Why do doctors strongly urge the public get a test done for thalassemia before getting married? From a lay perspective, doctor, we never sometimes hear saying get a cancer test done, get a screening test done before you get married, because those are also genetic issues, doctor. Why is this strongly advised?
One thing is the thalassemia, that is the commonest monogenic disorder in Sri Lanka. We have about like 800,000 carriers in the country, and the other thing is the screening tests are very freely available and very cheap. So you can any major hospital, any major hospital, you can get it done, those screening, and you can check your thalassemia carrier status. And the third point is the government is spending a lot of money only for 2,600, somewhere around like that amount of patients to manage these patients. It's a like huge burden, like roughly about like 5% of the health budget. So when we have a method to prevent this, so that is why not we don't take it.
Doctor, now once a patient is diagnosed, with thalassemia, what are the dietary restrictions that come along with it?
It's a good question, Mariela. So now trains, no dietary
No dietary
restrictions at all.
restrictions.
They are completely normal, no? But then again, there is a small issue with the thalassemia major. The other problem is the iron overload. I told you, we give them blood transfusions, and then excess iron in transfused blood will go and deposit in various organs, and they develop iron overload. Say they develop iron overload mainly due to blood transfusion, not due to food. So I think it's ridiculous to restrict iron-containing food for these small children, especially because most of these iron-containing food have a lot of proteins. So they need for the protein for their development and growth and development. So they can have, but excess iron is bad for them, the thalassemia major.
Doctor, now children, since if they're born with this disorder, genetic disorder, how do they continue their life in the long run? How does it impact their life? Small children.
Yes.
Unlike adults, they have the ability to understand, okay, I have this, there are certain things I have to do, but in the life of a child, it's a little different.
Of course, Mariela, that is when it comes to a life of a child, it is difficult. Of course, the thing is, once a month they have to come to a hospital, and then we have to place a cannula, we have to transfuse, and then when they develop iron overload, again we have to put a needle and take those excess iron out, and we have to early morning. Most of these patients, they receive a drug called deferoxerox in order to remove excess iron. That's kind of like very. I know difficult. It's a very hard life, but with time they get used to it, and the parents aspect, of course, they have a very big role in that way to play, because they don't understand the importance of iron chelation. The blood transfusion, of course, they tolerate to a certain extent, but then again, the chelation wise, they don't understand the importance of chelation. If they manage well from that small days onwards, so then they can have a completely near normal life. They can get married, they can have children, and a normal life.
Treatments continue, doctor?
Yes, treatment will continue, because each month we are giving blood, and each month we are pumping excess iron. So then we have to remove that. The treatment wise, we have to get again that chelated drugs you have to take maybe daily, depending on the amount of iron level in the blood. So that, of course, you have to continue lifetime.
This question might be a bit of a very sensitive question, doctor. What I have for you up next, the lifespan of an individual. Some say it's quite short.
Yes.
What are your thoughts on this, doctor?
That's a good question, Mariela. Now, earlier what they said, because of this, as you told, that these children, they are not into treatment. How much ever we try to urge them to take the medication, they are not willing to take treatment. So because of that, earlier, as per the calculations, what they say is the thalassemia major patient survival was somewhere around like their age is 13 to 14 years. But I believe that the figures have changed now, and we have under Professor Anuja Premwardana, we are doing a lot of survival analysis these days, and hopefully the figures we might get a kind of like good figure, because now the patients, that's why like we see an adult and adolescent thalassemia center in Sri Lanka. Earlier, of course, we had only pediatric boards to manage these patients. Now, because of this advancement technology and the good management, they are in good hands. These patients continue to survive. So maybe with new research finding, we might be able to give you a better result.
Definitely. Doctor, now you said during blood transfusion, you all are quite strict because diseases such as HIV can be transmitted through blood transfusion. However, if a patient is undergoing or has thalassemia, does this lead to other health complications in life?
Thalassemia per se, of course, that when a patient get thalassemia, because of the blood transfusion, they develop iron overload, and then because of the iron overload, they get a lot of complications. Like because this excess iron can be deposited in liver, causing cirrhosis. And then it can deposit in major endocrine organs, as I told you, from pituitary to thyroid to adrenal and the ovaries and the male genital organs. So those things, then the because of these endocrine disorders, they get develop different kinds of, like they develop and the iron deposition in the pancreas, they develop diabetes. Because of the thyroid issue, they develop hypothyroidism. They are, because of the pituitary gland involvement, their growth will be impaired, and they develop subfertility, like lot of complications. And also they are more prone to infections as well.
Right.
Because of this chronic nature of the disease.
Doctor, are there any lifestyle changes that you recommend? Another question that we got was, let's say if it's an adult, an athlete, do you recommend that they continue doing their sports? Are there any lifestyle changes that you all think a patient should not be doing?
You mean in terms of thalassemia? Major,
Yes.
Of course, Mariela, that we have never come across a kind of like athletes, because anyway they are anemic, and they, depending on the blood transfusion, they continue to survive. And otherwise they can have a.
Otherwise, you all recommend a patient to lead a very normal life.
They can have a normal life. Once in a month, they have to come to the hospital. They have to take a blood packet, and then they have to continue their chelation. That is the most important thing. This excess iron removal, that is very important in order to have a normal life. So then they can have a near normal life.
Doctor, you said they are prone to a lot of infections.
Yes.
So what is the care that they have to take to protect themselves from infections? Any lifestyle changes?
That, of course, now, like during the previous COVID season also, a few of our patients, of course, they died, maybe not due to infection, but then again, they are more prone to infection because of this chronic nature. And we ask them to wear masks, and if you can avoid excess gathering, those things, of course, those are kind of like general measures for any person to follow. So they can follow those things.
Doctor, what about...
and the other important thing is, now because of their disease, sometimes we may have to remove their spleen. You call it pleha. Okay?
Right.
Because of the disease complication, we may have to remove their spleen. When the spleen is removed, they are more prone to infections. So that's another issue with these patients.
Sometimes they say when you're sick, stay at home indoors, but you all say it's okay, take a walk, be with nature. Do you all give that sort of advice? Or do you all say it's best to stay at home?
Yeah, but if you have fever, of course, you can't have a walk. But that because the fever is a catabolic state, and you can't exercise, and walking, of course, you can't have. Otherwise, like a common cold, of course, just brisk walking is not bad. But then again, it depends on their hemoglobin level.
Right.
When they are closer to their very low levels, when they are very closer to their next transfusion, of course.
Then they have to be a little vigilant.
Yeah, because they, vigilant, and of course they can't perform. And then they tend to come to hospital because they say, no, doctor, I feel very lethargic, I'm very tired, like that. So on top of it, we can't recommend them to do any exercises like that.
So it's, when you think about it, it's a bit of a different lifestyle for them, isn't it?
Exactly.
Welcome back. We are on the final lap on this week's edition of the Spotlight. Doctor, we're on the final lap, as I mentioned. If a patient has thalassemia, how do you advise the family, friends, and their peers to work around this? Because, as you mentioned, this is a bit of a different lifestyle that the patient has to undergo. And sometimes people might get a little annoyed. But I think we have to go beyond that. And sometimes we have to be compassionate toward these people. But from your perspective, doctor, how would you advise family and friends to step in and be of some sort of support?
Well, Mariela, I think being a thalassemia major patient is, we should give them a kind of like near normal life. We shouldn't restrict them for, of course, the vigorous exercise they can't, but then again the other activities, of course, you shouldn't restrict. They should have a normal life. They should engage parties. They should be with other people, and their social activities should be continued, and their schooling, especially. We have our thalassemia patients. They have completed primary, secondary, tertiary education and university education. There are a lot of graduates in this thalassemia major cohort. So they can have a kind of like near normal life. The only thing is we advise is at correct time, you have to come to the hospital, you have to take your blood, and then the blood chelation, iron chelation, of course, you have to continue.
It all comes down to this timely blood transfusion,
yes,
isn't it?
Blood transfusion and iron chelation.
Are there any support groups in Sri Lanka that come in as responsible organizations for thalassemia?
Yes, Mariela. Now, earlier, of course, we didn't have supportive groups in Sri Lanka, but recently, about like 2 years back in 2021, few of our thalassemia major patients, they got together and they form an organization. That's called Lanka Thalassemia Organization. And it's a registered organization, and we see that these people are doing very well, and they identify the potential donors, and then they direct for needy people, and when they find problems with some kind of like some chelate drugs, if there are if there's not enough adequate drugs in hospitals, they discuss with the health ministry level and try to get down the drugs like that. They are doing a very good service. And Mr. Madhusha and Mr. Shaluka Premchandra, they are the main key leaders of that organization, and they are doing very good service. So the social well-being of these thalassemia major patients.
Doctor, in the near future, do you see that there might be a reduction in the number of patients in thalassemia?
That is, of course, I think I must tell something about the prevention. Then if you do the prevention properly, you can see a reduction. So the prevention-wise, Mariela, there are two aspects. I told you. The first one is you have to discourage the marriage between two carriers. The second option is the prenatal testing and termination of affected fetuses. If you take the second option, the prenatal testing, you know the meaning of prenatal testing, that is when the baby is inside the womb, we take the water from the water bag and we do the thalassemia testing, and we can identify whether the particular fetus is affected or carrier or a normal fetus. But this option is you can't implement at a national level because we do not have the legal provision to terminate thalassemia major fetuses in Sri Lanka. So therefore, our main national thalassemia prevention program is based on the carrier identification, carrier screening, and educate them and prevent marriages between carriers. So we have a very good career screening program. Earlier it was like, initially it was launched in 2007 with the help of the health ministry, but it was not earlier centrally coordinated. But then again in 2018 we relaunched this screening campaign. Now it is happening at regional level, and we are identifying a lot of carriers in the country. So if you know the carrier status, well, so we, after identifying them, we give them a card. You call it a pink card. We give them for the carriers. Normal people, we give them the green card. And then what we tell them is, when you marry, just check whether your partner is bearing a green card or a pink card. And if the partner is bearing a pink card, you shouldn't marry.
Right. Very simple.
Very simple.
Pink or green.
Pink or green.
So, Doctor, my final question for you, or your final message. What is your take-home message to everyone watching us today? Some final thoughts.
Finally, my take-home message is, these thalassemia patients, if they're well managed, if you take your blood transfusion in correct intervals, and if you take your iron chelators properly, you can have a completely near normal life. Thalassemia major patients, of course, you can marry, you can get babies, you can have babies, and you can have a normal life. Thalassemia trait patients, yes, you know that you are carrier status, you are a carrier, and before your marriage, we recommend you to screen your partner whether the partner is a carrier or a normal person, and we discourage the carrier marriages between carriers.
All right, Doctor, thank you very much for joining us today. And on that note, we are hoping for a better and a healthier Sri Lanka in this, and we thank you for the service you are doing as well.
Thank you, Madil.
On that note, we are ready to wrap things up. Join us again next Monday for a story that will ignite change. Until we meet again, stay safe and have a pleasant evening.